You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast. This is part 3 of a 3-part series on geriatric care. And in this episode, we're really going to focus on improving communication and decision making. And we're going to do this with Iain Wilkinson, who's joined us in part 1 and part 2. We're also going to do it with Georgie Gill. So what we're going to do is really uncover some of the best practices for engaging families in decision making and addressing some of the complex geriatric syndromes. We're also going to look at managing conflict around patient autonomy. We're also going to discuss the importance of collaborative training and measurable models to improve communication and outcomes across healthcare systems. So we're joined by Georgie Gill in this episode. She is a Trainee Advanced Paramedic Practitioner working in South East England. After working as a paramedic in NHS Ambulance Services, she moved to work as a teaching fellow for a Department of Elderly Medicine, balancing contributions to MDTea podcast, which will feature in the show notes, to teaching multidisciplinary teams and serving on the front door of frailty teams in emergency departments, bringing insights and expertise to paramedic practice in this area. So following this, she moved into Community Frailty Services, working in advanced care planning with older adults residing in community settings before moving back into pre-hospital care to undertake a Trainee Advanced Paramedic Practitioner role and an ACP MSc. So we're also joined by Iain Wilkinson, who has indeed joined us on part 1 and part 2. He is a consultant geriatrician and wears many other hats as well. Welcome both to the podcast.
Hi, thank you. Thank you for having us.
Thank you for having me.
I wonder if you could just start, Georgie, I'll first come to you and just really want to get your perspectives on some of the bigger barriers really to effective communication between pre-hospital and in-hospital teams during that sort of tricky transition of care for elderly patients.
I think there's sort of a myriad of challenges that affect especially older adults at that point of care. Some of them are systemic, some of them are individual. So a really big system level one that I really props to mind very quickly is that no handover setup is the same between any hospital. In the area that I practice, I could go to 5 different hospitals in one shift, and every single one has a different handover format, a different layout. It wants different expectations from my handover. And so that makes it really challenging for pre-hospital care teams to know what information is most relevant at that time. Add into that, there's a challenge that the research has shown us that nursing staff, the ideal handover that they want to receive in the ED setting is a patient with a clearly defined medical problem. They least like patients with more complicated care situations, which is arguably almost all older adults that are conveyed to the ED. And so therefore, that makes it really challenging, because as a provider of that handover, you are always on the back foot of knowing what that person receiving your handover wants to know most. And that's also contributed by the fact that some research has previously shown that there's low levels of interprofessional trust, which I would argue is probably because we all don't know what the other one wants. And that really puts it on the back foot, really. I think also, I'm sure other areas of the country would agree, but I don't know if hospital staff always know what grade of staff is handing over. We all wear green. We all have something written on our shoulder, but that doesn't actually line up with what hospital staff know as the sort of grading system of what a clinician is. So an ECA could be handing over, which is the equivalent of a healthcare assistant in the ED setting, but someone's not going to know because we're all wearing the same green. And so the quality of handover that they're provided varies a lot. And I think that, again, affects that trust and how information is then carried forward. I think on an individual level as well, what can we do, or what are we affected by as individuals providing that handover? I think that the information that we're providing isn't like anything frailty specific, something about the social care needs of a patient, something about their mobility, just isn't prioritised at that handover point from us. So we might collect all this vastly useful information that actually in the ED is just not that important right there, right then, but it feels important to us. So I think there's that disparity of knowing what's important again, which is the same theme. And I thought finally, handover isn't a taught process. It's something you pick up ad hoc through your experience. It's something you watch numerous clinicians as a student and you think, I like that, I'll take that. I don't like that, I won't do that. But actually, especially for our internal staff who might have trained up through the professional sort of ranks, I guess, they're not getting to see that handover because one person will stay with the patient in the corridor or on the back of your ambulance, and one person is providing a handover. So we're not seeing each other's handovers unless it's that traditional big job. And then it's most often our most senior colleagues who provides that handover. So it doesn't give our newer staff experience doing that either. And just one day you're sort of thrown into this situation of giving a handover about something that's actually really complicated.
Yeah, indeed, indeed. And you make some fantastic points there, Georgie. Iain, to yourself.
Yeah, so I think Georgie sort of said most of the things I was thinking about, but I think linking back to when we talked about delirium and frailty and the clinical frailty score, I think there's something there about commonality of language and us using the words that we all both understand. I think there's something about the complexity of older people, and exactly as you were saying, Georgie, that when an older person is, next to those ambulance doors that we call them ambulance doors, the front doors of the hospital where the ambulance service come in, there is a whole bunch of information that the ambulance service personnel know that is going to be hugely relevant and useful in 2 days' time. And that concept that you talked about, Owen, about information entropy, that information starts all in one place and then just gradually drifts away with each handover that then happens from, to the triage nurse, and the triage nurse to the nurse in resus or majors or minors or wherever the patient ends up, and then that person to the first doctor, and then that to the second doctor. By the time the people that want that information, so the MDTea on the ward 3 days later, when they want that information, it's now disappeared, and it's only encoded in that, any photos or bits that you guys have written down on your sheet when people come in, but all that beautiful sort of narrative data has disappeared. And I think that's the one of the big issues, is that how do we encode this data? How do we get this data in a way that actually it's still there when we want it, so that people aren't then recollecting stuff that actually as a system we already knew and we've just forgotten it over the last 3 days.
Just looking at, you're absolutely right, and to both your points, and it's like you say, decoding the information, understanding there is valuable information, but not, Georgie, to your point, not overwhelming the recipient of that handover with an array of information, putting it in sequence of priority, but somehow capturing it, like you said, Iain, that it does bear relevance. The social context bears relevance. The mobility at home bears relevance. The elements of self-care bear relevance. Maybe not at that moment, but they still do. And it's understanding in capturing the information in sequence. Just looking and pivoting slightly, and Iain, I'll come to you first. Could I get you to speak? So you spoke to on the last podcast around just simple things like cleaning patients' glasses, just so that you can, or they can, start to really just see properly, and there's but optimization across the spectrum, just simple things first. But could I get you to speak to how sensory impairments such as hearing loss or vision difficulties impact our interactions with elderly patients, and indeed what strategies, or maybe the simple ones first, can address some of these challenges?
So I think, so I think community is a bit thin here. Communication is information, isn't it? And it's going bi-directionally. And so I think there's issues both ways, both in terms of the information you're trying to transmit to your patient, and then the information they're trying to transmit to you. I think in terms of us giving information, I think some of the things we talked about before are pertinent, about segmenting the information so that it's in understandable chunks. I think assuming someone has capacity is what the Mental Capacity Act says we should do, and it's absolutely the right thing to do, I think. So assume people have capacity to understand and try and start there, and then maybe work up or down depending on how much you feel they understand. I think trying to maximise what people can see and hear is all going to help prevent delirium in the future and make sure that you have a better interaction with the patient. And so I think that's about lighting, making sure that the light is on, people can see you, they can see your mouth, you can see them. That both for hearing and sight. That I think if people have got hearing aids, it's making sure that they've got them and bring them to hospital. And if they've got a box with them in with a whole load of batteries in it, bring that too. Glasses, people have lots of different glasses. They have some for near sight, some for far sight, some for reading, some for driving, all that and the other. Trying, if it's possible, to find out the ones that are most relevant to a time in hospital, so that someone's not sat there with their driving glasses on for great distance when they're trying to read the menu in the hospital.
The only thing I had to add was also make sure you're actually speaking to your patient. I think it's really easy when there's, especially in people's houses, there can be 4 or 5 relatives in the room and a carer and the patient. And it's really easy for that patient's ability to interact to get lost within all the other voices in the room. So I think even if you've realised, hang on, this person might not be understanding me, they might be too confused, or they might not have the ability or the attention to engage with this, I think there's still a value in speaking to them directly, even if you then are making eye contact a little bit with their relative, with the intention that the relative answers the question, because I think including them is respectful at the end of the day, but it also is empowering.
Yeah, the thing I was trying to think about when I was saying earlier about hearing, and I think we've all got stethoscopes, and if you reverse your stethoscope, it's a great magnifier for sound. So if you put the earpieces in your patient's ears and then you talk into the other end of the stethoscope, that can sometimes, if people are quite deaf and they've not got their hearing aid or they've not got a hearing aid, that can be quite a useful, just little trick sometimes.
So let's come to handovers, because we've already spoken at length about handover, but I think what we've omitted and what we should maybe double click on is really what we should include in handovers, some of the fundamental information that we should include, and that should be front of mind to Iain's point. So we're speaking a universal language. So Georgie, could I come to you first and get you to really speak to what key elements should be included in handovers to ensure that geriatric patients receive safe and effective care upon arrival?
I think foundationally, when talking about handovers about older adults, we just have to accept that they're not going to fit the nice traditional boxes of a handover structure. They're not going to fit our ASHIs or ATMIST work format. And I sometimes don't think S-bar is quite right either. And I know that's pushed in the NHS, but I don't think that's quite right for the acuity of which an ED handover between ambulance and pre-hospital is. I think one of the key things to include in a handover is about care planning. Does the person have a respect form? What does it say? And what's the context of your conveyance? Lots of the time we are conveying people for a full workup and treatment because that's their wishes. But if they have documentation that's perhaps not supportive of a hospital conveyance, why are they here? What challenge have you been unable to meet in the community? And articulating that, I think, is really important, because that might be setting the tone for where this patient's journey is intended to go. We can't control where it does go, but I think it's setting an intention. If we're not telling people that, then we can't pass on any information, can we? I also thought about, related to handover, is the idea that documentation of information does need to be designed to be readable. It needs to be easy for future clinicians down the line to be able to find that information that we've put the work in to find, but isn't required immediately in the ED. So I think it goes back to what I said before, is knowing you need to know what the person in front of you needs to know.
As a doctor, I think there's so much, particularly if somebody's confused, that is really important in that presenting complaint and that history of presenting complaint and what things looked like at that first point in time. So, for example, I've got somebody that I've been looked after in the last few weeks who presented with intermittent sort of neurological signs, and just having the really good description of what happened from the paramedic, which we found, was just so helpful in terms of describing, because this is something that happened a few times in a few hours. And actually, the debate for us was like, is this absolutely sudden onset? Is this a TIA or stroke type syndrome? Or actually, is this more like a seizure or temporal lobe epilepsy or something else, that's here? And actually, that initial description was so clear from the person who was actually with the patient when this happened. Actually, it made such a difference to us down the line after the first set of investigations, trying to plan what next. And so I think that was really helpful. And I think what you were saying, Georgie, about making the notes legible and readable directly relates, because the next patient, I needed to find out some information about the home, and actually the paramedic had taken photos of the home and they were embedded in the paramedic handover sheet. But we get that as a PDF thing. So we're finding it, trying to drag it to the right bit of the PDF, zoom it in, and then these little tiny little pictures get larger and larger, and so it was all there and it was fine and it was great, but it took like 5 minutes to once I knew the document that I wanted, to export it, to find it, to enlarge it, to actually be able to read the information that I wanted. So I think they're two really key points. I think it's the detail, and medicine for older people is all about detail, small little details, and knowing when you have to delve in to a lot of detail and when you can have that more of a helicopter view and not do that. And readability or accessibility, and finding a way, in an ideal world, we would have one clinical record, wouldn't we? And then, if you're sat at the patient's bedside at home, you would be able to see everything that's going on about them, and see that they saw their GP 2 days ago and they were in clinic 3 weeks ago, and all of that would be readable in an accessible way, and you'd write some stuff down and that would arrive in the hospital and it'll be accessible to everybody, but we are some distance away from that still.
So just looking at maybe case studies or indeed examples of where poor or incomplete handovers have negatively impacted the trajectory of care for elderly patients' outcomes, and how these issues could have been affected. I'm double clicking on handover, because you said something fundamental earlier, Georgie, which is we're not trained in handover, yet it's one of the most risky parts of the patient journey, and transitions of care are risky. It's this vicarious learning through mentorship, but there's no quality assurance that that's the right way, and so there's no systematic training. So it's really important, because when you look at error chains, this can be a fundamental part of, like you said, complex. Geriatric care can be complex in a multitude of ways, with an overwhelming amount of information. Could I get you to speak to your thoughts on how we can stop some of these negative impacts of care, and indeed, like you said, maybe train better for them through feedback mechanisms? Or what are your thoughts, Georgie?
I wholeheartedly believe that feedback mechanisms would be brilliant and have a really big impact on how our staff can learn and improve, and the quality of handovers would I think improve. Evidencing that is a lot more challenging. There's quite a lot of work out there about different feedback mechanisms in the pre-hospital environment, and looking at that feedback point between that handover of ED to hospital. A lot of it does look at patients who are maybe that more major trauma patients, those MIs, those STEMIs, but it does exist for those patients who are more of our maybe day-to-day, what we'd call generic ambulance patients. In my clinical experience, we're still just not getting quality day-to-day feedback. The feedback I'm getting at work is generally, I have to go and find the nurse because there was a particularly interesting patient, and they might be able to remember who I'm talking about, or I'm getting, our key performance indicator feedback from my employer. But that doesn't tell me how the feedback, like how my handover has affected my patient, or how my care has affected my patient's journey. There just isn't any way of getting that. And creating these feedback systems while I was working as a teaching fellow, we set one up at East Surrey, and it was effective. We had some really interesting feedback. We had some great engagement from crews, but those systems are so reliant on someone being passionate and interested and wanting to set up and run this process. As soon as that person isn't able to, for whatever reason, then it just falls by the wayside again. And that means our staff are missing out. It means our patients are missing out. I think we can make an educated guess that every day there are patients that are conveyed to the hospital for a condition that's either manageable in community, but there's been some systemic reason why we can't manage them, or they do need to be there. But these patients are so complicated, and their journey and flow through the hospital is so complicated. The hospital team, and even they might have had another community healthcare team that referred them to the ambulance service. Then they go to A&E, and then they go to MAU, and then they go to a ward, and then they're managed by a social care service. That it would be really difficult to extrapolate which point of handover was the one that affected them, because they are just so complicated.
Feedback's important for two reasons, I think. One is trying to make sure that the handover process itself is improved. If you come to hospital and you give a fairly shoddy handover and no one ever says, by the way, mate, that wasn't that good, you're never going to know. So you'll keep doing the same fairly shoddy handover and think you're doing a good job. Equally, if you do a great handover, someone should go, you nailed that. That was really helpful and that was really good. Well done. That's the way we want everyone to do it, or and sort of pick you up a little bit, because we never get enough. Well, we never get enough positive or negative feedback in healthcare, I don't think so. So I think that's part of it. And then I think there's something about the kind of the next patient. So if you and I think I touched on this before, this idea of illness scripts, that you have this sort of condition script or library of a condition in your head. So if you've got someone that's got a DKA, you kind of have an idea of what a DKA, someone with a DKA might look like, and the pattern and stuff. And the more that you get feedback that yes, that patient did have a DKA, the more that you start to add flesh and colour and depth and substance to that illness script, and the more likely you are to spot that same condition in the future. But if you are never able to seek that feedback, you drop somebody off that you think's got DKA, but actually we find out they've had, I don't know, a STEMI that got missed, or something else that presented in a similar way, then you never finesse that illness script. And so next time you go, you'll go, oh, well, that's DKA, but it's not, and you get it wrong again. And so I think feedback's important for developing one's own clinical skills, let alone the handover skills. And both of those things are beneficial to patients.
Let's switch pace slightly and look at the role of empathy, and the role of empathy within interactions with elderly patients, and the fundamental tenet of communication. Could I get you to both speak, and Georgie, I'll come to you first, about how we can maintain sort of the cadence of empathy throughout a high pressure situation, or indeed an acute patient with an acute need, but still not negate that maybe that vital empathy, which is the bridge to communication and indeed to rapport.
The immediate thing that came to mind when you asked this question is the phrase "slow is smooth, smooth is fast," and I think it's a well used in pre-hospital, but it's an incredibly useful quote that can be applied to any situation. And I think it's just take a breath, take your time, talk kindly. Quite often on these interactions, you're dealing with a worried patient, a worried relative. Often, a husband or wife, they could be married, decades, 60 years or so, is really common for me to come across. And that the more experience I gain, the more I'm confident in the power of watch and wait, take a deep breath. You can still move smoothly. And if that patient is in need of a rapid or timely conveyance, that's much more effective and much better experience for patients and their families if we just take a deep breath and be smooth. It's, care of geriatrics is very rarely high pressure in the traditional sense. But it's high pressure in the way that your decision might have a significant impact on that patient's future journey, much more than maybe younger patients. So take your time, think your rationale and your usual clinical reasoning to make the right decision and involve your patients in it. And just take the time to explain it to patients, I think. So really, it's all just coming down to time, isn't it?
Yeah, and Iain, to yourself.
Yeah, so I think empathy is a core skill for anyone working in healthcare, and I think it's the human aspect of what we do. And I think when you lose empathy, if you lose empathy, there's a big link, actually, research link between level of empathy and burnout, and I think it's related to our satisfaction at our job as well. And there's some research. There was a nice study in the Royal Society of Medicine journal from 2018, I think, looking at practitioner empathy and the communication of positive messages to patients and patient outcomes. And actually, there were significant, relatively small, but significant patient outcomes, particularly in pain. And I think one of the things pre-hospitally is for various reasons, you see quite a lot of people in pain. And I think being able to approach them in a caring, sympathetic and empathetic way is going to have a significant impact onto the way that pain feels for that person. And that's something that is really, really important.
Yeah, absolutely. I couldn't agree more, actually. And as an enduring sense of care, I think it's one of the things that patients, and certainly elderly patients, remember. Of course, we want competent clinicians, but we really need to address that sense of pain management, as you said, in a calm, consistent way. Just to de-escalate. That verbal de-escalation, I think, is key. And as you said before, actually, the verbal de-escalation and this sense of empathy isn't necessarily trained for. It's a key tenant, key skill. And it's also, like you said, it fluctuates over time. And I think being a reflective clinician, it's really prudent to understand, I think, where you are on that scale, but both on a row of shifts, but also throughout the trajectory of your career, so that you are still turning up and enacting that sense of empathy.
There's a I think she's a sociologist called Nell Noddings that's written a really good book chapter called An Ethic of Care. And in that, she talks about the difference between caring for, caring about, and care giving, and then care receiving. But I think some of my research looking at geriatricians suggests that most geriatricians sit on that care giving, active delivery of care. Like I talked about the other day, actively cleaning somebody's glasses is an act of care giving. I'm caring about the fact their glasses are dirty, but I'm doing something about it. And I think people that are comfortable working with older people often sit more on that side of that spectrum. It's not right, it's not wrong. It's just where people tend to be, and more able to deliver active sort of hands-on care, rather than sort of a slightly more step back thing. And I think that links into the empathy discussion we have.
So Georgie, I wondered if I could get your thoughts initially on collaborative decision making, and just maybe speaking to some of the best practices in your mind for engaging families in decisions about elderly patients' care, while sort of balancing patient autonomy and indeed family input.
Ultimately, this comes down to sort of advocacy for your patient. You're not in healthcare really ever asking a patient to make a decision about their care. You're asking for their ideas and thoughts, and you're giving recommendations. And you obviously, in the context of pre-hospital, you cannot kidnap your patient to hospital because it's the right decision if they have capacity. But I think with older patients, there's a role for advocating and supporting how they make decisions, how they access and understand the information they're given about a decision, and the role of family as well, and how families can make decisions easier sometimes. they can make them more complicated sometimes. And you, as an ambulance person who's never met them before, have to sort of come and sort of mediate and sit between that and balance some very quite often complex and historical family dynamics and pick all that up within 5 minutes of meeting everybody. There is a real skill in balancing families. But I think draw on the resources that are available to you. We have come a really long way pre-hospitally now. I don't know of a service that doesn't have some supportive remote decision making set up. So in my area, we have our paramedic practitioner hubs that we can call at any time. So you can ring them and have a discussion. And even I've put them on speakerphone to be a neutral, non-emotionally involved person, because much as you're coming into that situation with neutrality, if you're there on scene with a patient and you're looking and you're watching and you're seeing, you become emotionally invested in that situation. So sometimes when these decisions can be really complicated or the dynamics can be quite challenging, having someone who is not there face to face helping can be really useful. I think also observing what you do and don't like from other people's experiences is also really valuable. For engaging families, you might just see something and you think, God, that was really great that that person did to draw that family member in, or explain to them why their loved one is able to make their own decision. A recent patient that really comes to mind that I had this sort of dynamic with is a lady who was having an acute loss of mobility. She's stuck in her armchair and she'd had 3 ambulances that day because the carers felt they couldn't meet her care needs anymore because she's stuck in this chair, which is completely fair. However, she did not want to go to hospital and she was very adamant about this. And the carer on scene just could not understand why I couldn't take her to hospital. She couldn't understand, and every sentence that she was saying was, well, you're not going to hospital. Why are you not going to hospital? You need to go to hospital. And really pressuring this patient who did have capacity at that time and is well within her rights, regardless of whether I think it's the right decision or the wrong decision. She's allowed to make that decision to stay at home in her chair as long as she understands all the challenges and the sort of what the potential negative outcomes of that might be. I think finally, when it comes to patients who perhaps lack capacity, I think it's very important to make clear to families that you're not asking them to make the decision. And I think we often think about that with resuscitation or decisions where we might say, actually, this patient's really complex. They're in a care or nursing home. Their Rockwood score is 7 or 8. They've had 5 or 6 recent hospital admissions for recurrent infections. Is this the right decision to be conveying to them to hospital and starting an end of life and palliative care journey for that patient? I think it's really important that you're making recommendations, but you're not asking family to make that decision. That isn't a decision that they should or have to make. You don't want them blaming yourselves. You just want them to be involved. That's the most important part there.
Yeah, so yeah, like you said, not instilling a sense of burden upon them, but giving them the decision so that they can come along on that journey. Iain, to yourself.
I don't know if I've got much to add to that. I think, Georgie, you spoke to that very eloquently. I think the point about us being an advocate for our patients is key. And the link between that and as you described really nicely, the discussion with relatives, it's treading that line between how much you are asking for assistance versus how much you're saying this is what is the right thing for us to do here and now in this moment, and this is what we're going to do, and trying to understand at speed the underlying family dynamics and politics that go around with that to try and make sure that we do the right thing for our patient. Now, if the patient is able to talk to us and tell us, that's great. If they're not, then that's harder. I think also being aware that when we're advocating for our patient, for older, frail people, as we've just discussed before, coming to hospital is not a general panacea. It doesn't fix a lot of things, actually. It fixes, some acute illnesses definitely very much need to be in hospital, but there is an awful lot we can do and manage with people at home. And so I think part of our advocacy role is knowing those alternative pathways and being able to pull those levers, and knowing what lever you've got at what time of the day and what particular county at what day of the week and all those variabilities within that, to do the right thing for patients. And that is not always, as you described, coming to hospital.
Let's look at care planning for a second, actually, because Georgie, you've mentioned it already. But I get you to speak to how pre-hospital clinicians support advanced care planning discussions for elderly patients, and indeed maybe what role the hospital has in collaborative working in this regard.
When I was working as a community frailty practitioner, the biggest thing I learned when it came to care planning decisions, so in my area, a big part of that role was writing respect forms, which are a national, they came out of do not resuscitate forms, but they have a little bit more depth to them. They sort of talk more widely than just the actual act of resuscitation. They talk about levels of care and what a patient would and would not accept in their care journey. But I think the thing I came across the most was the patients who were most open to having those conversations and had the most value, I think, out of those conversations was the people who had maybe had that conversation started by someone else before. And quite often that is our ambulance service colleagues. They might just say to the person, "Oh, do you have a respect form?" And the patient doesn't know what that is. But then they explain to them what it is, and it just plants that seed for patients to kind of think about and reflect on what they would and wouldn't want in their care. And starting that conversation it made my job a lot easier if patients have thought about it ahead of time. And on the similar thread, I think from a hospital perspective, what role does hospital collaboration play in this? I think it's when you are writing those documents, make them clear and effective. And they are a really complicated document to write in the sense that there is a real nuance and every single patient is unique in what you write. But that, I think, I don't know whether Iain will agree, but I think that's really, really important in them. And as a community professional, like attending a patient at 9 p.m. on a Friday night because they vomited twice and they live in a care home, if they have a respect form that simply says ward-based ceiling of care, not for ITU, not for HDU, that doesn't have any usefulness to my decision making. So I am already on the back foot, because if I have a respect form that isn't particularly supportive of my decision making either way, and I don't have access to their medical history, and at that time of night I might not have any phone numbers for family and friends or relatives or people that are important to this patient, it's really difficult to make an effective plan that's patient-centered and the right decision for that patient. So I think writing care plans that are clear, concise and effective for both hospital and community is really important.
I absolutely agree. I think the respect form is one of a number of advanced care plan documents, and it's not perfect, but it's a lot better than a single red formed DNA CPR form, I think. And often what happens though in hospital is you might start a conversation, and then when somebody is unwell, you might have the CPR bit of the conversation with the intention of coming back and having more later. And if I'm honest, I think in hospital sometimes we leave some of the more junior members of the team to have these really quite complicated conversations with people, and it's very easy for us to get focused on the here and now, i.e., in this hospital bed, this is what we're writing down because the ward-based ceiling of care, or not for ITU, or this, that, and the other. And I absolutely agree, it's of zero use when you're out of hospital, and that comes down to the information that person that's with the patient needs in that moment in time. And there are things that we should be doing in hospital. A respect form is about what would you do in an emergency situation, so that should be on it. But also, when people leave hospital, we should be thinking and saying, actually, well, let's update this now. They're going home. This is now not relevant. It's relevant if they come back into hospital, but actually let's flesh this out with a bit more information, and we should be doing that. I think that will come with time, because respect forms are relatively newly rolled out across different areas of the country. So it's not like it's something that's fully embedded and completely integrated across all care systems yet. With time, I think we will get better at doing that. But you're absolutely right, we're some distance away at the moment, I think, from having an advanced care plan that's shared across all the systems, that is helpful for everyone in each situation.
So let's talk about navigating complexity. We've notioned towards it actually with the handover, and actually, as you said before, Georgie, around training better. So there's universality of handover. I know what format you're going to give the handover to me in, albeit bespoke to the patient population. Like you said, it's not necessarily an S-bar handover, but it's something which is appropriate and captures all the information. Could I get you to speak to how pre-hospital and indeed in-hospital teams can better align in managing geriatric syndromes like delirium, polypharmacy, or frailty? What are some of the collaborative tools we could use to sort of maybe come closer together on those?
I think Iain alluded to it before, didn't he? He spoke about the importance of standardized language, and I think that is a really key part. If we're all using the same language, we can all, we're all following the same line then. I think the use of the phrase delirium is really, really quite new pre-hospital. The phrase acute confusion really, I think, was what was previously, and it's still in our how my trust records our like data coding. We don't have delirium, we have acute confusion still. And I think that is also quite a dangerous phrase, because it really fails to acknowledge the hypoactive delirium patient. So I think maybe that's something to take forwards and to be changed. I guess the big area for navigating the complexity of older adults that is starting at the moment in the UK is the growth of virtual wards and community frailty teams and urgent response teams, or rapid response teams, whatever title the service in your area has. They exist, and I think they have a real benefit in making sure elder people get the right care at home, but that can be focused by like specialist clinicians. And so I know in our area we have a frailty virtual ward, so we have a geriatrician accessible for those patients in community. I think there's probably, and I don't know if Iain agrees, a benefit in if we had streamlined services, so services that streamlining to avoid ED. But there's also there's also something to be said for either making criteria for those services very clear, or accepting that sometimes we're not going to get it right because pre-hospital services just don't have the breadth of information, making every referral perfect for those patients. And some patients will slip through the net and get in when it's not appropriate, and some patients will miss it because we just don't have the information. But I think there's something to be said about having those streamlined services to get patients to the right place first time and avoiding that sort of, I don't know, middle zone of ED where perhaps more information can get lost. And more things are there to change, I think.
Iain, to yourself.
Yeah, so I think the drive that's been happening over recent times with medicine for the older people, I think is going to be enhanced and made much more rapid, given the Darcy report of 2024 that talks about a shift from hospital to community, both a shift in terms of where care is delivered, but also where money goes to drive the services. And I think what that's going to start looking like is a greater use of technology to hold greater risk in the community. And that sits with the virtual ward that I think will start calling hospital at home across the country. And so we'll have this more integrated system able to hold greater risk safely in the community. And then the pre-hospital teams, I think, will be able to link into that. There's a greater rise in same-day emergency care and a real push for that, partly to sort of reduce the hospital bed usage, but also, we know it's the right thing for patients if they're able to be managed in hospital. And I think that then comes on to the question, but well, what are we gaining in hospital if we can monitor people and safely? Let's assume that the nursing type care is safe and able at home. I think what we gain in hospital is rapid diagnostics, and so then I think you're then in a position that as a pre-hospital provider, you're seeing somebody, you have an idea of what needs, what you think is going on. You've got a differential diagnosis, and then hospital is your route to filtering your differentials with a series of rapid diagnostics. And that's where the same day emergency care, I think, comes in, where you can avoid ED by calling one of your SDEC units for that day or the next day. The patient can then go in a semi-urgent, well, in an urgent semi-elective capacity, can have the rapid diagnostics, and then hopefully be onboarded onto a system and managed at home. And I think once we get to that, so it's a long-winded answer, I think the integration will get greater, because that's going to be the route, actually. And at the moment, you as pre-hospital staff only integrate with ED, really, because you don't really have anywhere else to integrate with, and some community teams. Whereas actually, as we start getting more same-day emergency care, onboarding people directly onto step-up virtual wards and hospital at home, suddenly there's options that are really, really viable, that are quick, and then we have shared decision making, because you'll be calling somebody and there'll be a conference call and we'll make a decision on the run between all those people.
I also think that having those joined up, like at the moment in my area, we have a trial where we have the urgent response team, we have a geriatrician, and we have the ambulance paramedic practitioners, so our ACPs, all in one room, collaborating, talking about incidents that are going on. As a clinician who is using that service to call in and say, I've got this patient, what do you think? I think that collaboration will also really improve confidence. And I guess that goes back to what we were saying about the feedback, but it improves your confidence in, okay, this patient's going to be picked up the next day and I know what their onward journey looks like, but they don't need to go to A&E right now. And I think there's a real benefit in that as well for patients and staff.
Absolutely. I agree with both of those comments, actually. And weirdly enough, I think it's sometimes around the user experience for the pre-hospital clinician to make it an easy, a frictionless option to utilize same-day emergency care and or referral pathways which don't involve hospital. And almost it is about the patient, but almost making it easy for the clinician to do the right thing. Therefore, streaming your patients into the right care pathways. Could I get you to speak to something which is quite difficult, actually? And Georgie, I'll come to you first, and then to Iain. Just around the disparity that pre-hospital providers can really face on scene when family advocate for decisions and or interventions that maybe conflict with elderly patients' wishes or best interests. And sort of maybe aligning those, and we've kind of notioned towards this before around the Capacity Act and fundamentally when a patient's got capacity, but it can be really tricky to find a middle ground. Could I get you to speak to that, Georgie?
Yes, I think a big part of this comes down to the individual clinician on scene's confidence with what the legislation says we can do and what our moral and ethical part of us says we can do, and balancing our moral compass and our ethics and what we know about not causing patient harm and making sure people get the right care in the right place at the right time, balancing that with the legislation and the preconceived ideas of patients' loved ones, because people quite often don't understand the hospital system or the healthcare system, or they think what they heard happened to a friend of theirs mother or a friend of theirs mother's brothers, etc., etc., is going to definitely happen to their loved one. And also I think there's something for taking an interest in what are their concerns, and where you can, but without dancing around the subjects or I wouldn't say lying, but to that interest, I guess, of maybe missing information or excluding information to make it easier for the conversation. I think there's something to be said for using senior clinicians to help, or remote decision making. It provides a non-biased ear and a phone line, and it's recorded as well. So if things are incredibly difficult, which they very rarely are, but when they are difficult or angry or agitated, I think there's a real really good benefit for that. But also just advocate for the patient and be confident. Sometimes there are alternatives and patients want our alternatives of hospital, but sometimes that just isn't right. Nothing exists. For example, going back to my patient who was stuck in her armchair, there isn't an alternative pathway for her other than hospital, regardless of how much she might really wish that someone could do something else. That just doesn't exist for her at this time. So I think it's being okay that it doesn't always work.
One of the things is about when there are, let's call them conflicts. I think one of the things is about understanding where that comes from. And that understanding leads to and comes from our empathy, as we were talking about earlier. And when, you'll know this more than I, but when you are looking after people whose loved ones are acutely unwell, they often look at their worst when you're first picking them up because they've not had any treatment yet. It's a very stressful time, and there's a lot of transference and counter-transference of emotion that goes on, and a lot of feeling of concern, worry, maybe guilt, all sorts of things, and that can bubble over in all sorts of different ways. And I think managing that well comes from understanding where it comes from and using your language, using your words to convey that, I understand this is a really difficult time without it sounding trite or whatever, and trying to convey to people that you understand what's going on and you are there to try and do the right thing and try and do the best thing and work with them to navigate this very complicated system that we've got.
As we're coming to land, just could you speak to what you perceive to the benefits of joint training could be to maybe indeed enhance communication and empathy skills from pre-hospital providers, indeed with in-hospital providers when dealing with elderly patients? And then as an adjunctive question, could you speak to maybe some resources that you recommend people go on and listen to?
For joint training opportunities, I think it's quite a challenge around what joint training opportunities exist in the realm of geriatrics, particularly. There's certainly a lot less of an investment in that, or there's less of it than perhaps in other areas of what is traditionally more exciting pre-hospital care. But I think if you can get an opportunity to go and work alongside district nursing staff, community services, in your A&Es and in a ward, so like geriatrics wards, it is so eye-opening to learn about outside of the system that you're in, because the pre-hospital system is so nuanced. We train inside our own system. Our student paramedics come up through our system, so they don't really, unless they have really great placement opportunities, or during their course, they're just not getting that information and they're learning inside a silo. And I think I said that when I first ever had any contact with Iain. I complained about what a silo it is to work in. And I just would absolutely say, if you get any opportunity to go and work with someone else and see something else, it will enhance your practice a lot. And I think that's been the biggest area for me to sort of grow and understand my practice a lot more. It's made me a much better, more empathetic, more reflective clinician. For training on resources, things that sort of came up was I thought about the MDTea podcast. I'm mildly biased, but I do think it is probably brilliant for that wider geriatrics knowledge. But any way of improving your overall breadth of knowledge in this area, I think will always really help. And realizing that it doesn't have to just be clinical learning that you're doing, but actually thinking about sociological concepts is also really, really important in being a wider, more diverse clinician. And then I also thought about your knowledge of local pathways and trying to use them. If you think someone meets the criteria, give it a go. If the referral doesn't work one day, don't let that stop you next time you have someone who might meet that criteria again, because it might work. So keep using it. And the more we put pressure on these services to take referrals and show that there is a need for that service's existence, the more money and investment they're going to get. So I think it's really important that we keep using our pathways.
And Iain, finally to yourself.
Yeah, so I think just in addition to that, I think the British Geriatric Society has got some excellent e-learning opportunities. There's more coming online, and later on this year, we're also going to have a whole series of sort of micro learning opportunities, which will be much quicker to go through than the full large e-learning modules. And if you join the BGS, there's also special interest groups and all sorts of stuff that I think are of relevant, including community care. So I would heartily recommend that. And on the e-learning for health website, there's also loads and loads of really good resources for anyone that works within the NHS and works within England, unfortunately.
Listen, thank you. And it's been a pleasure just to walk through this this last interview with you both. Just get your reflections and indeed thoughts from practice, because experientially and anecdotally, it's really powerful to bring some of these, hang this information on some case studies. So Georgie and Iain, thank you for the last 3 episodes. It's been really powerful just to get your thoughts. But Georgie, equally, thank you for today.
Thank you.
Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.